Hello and welcome to the Doc Podcast. I'm your host, Dr. Mike DeLuke, and it's my mission to help you lead a happier, healthier, and more prosperous life, both personally and professionally. Hello and welcome to this episode of the Doc Podcast. Today, I am thrilled to be joined by Dr. George Mandelaris. George is a diplomat of the American Board of Periodontology and Dental Implant Surgery, a clinical assistant professor in the Department of Graduate Periodontics at the University of Illinois College of Dentistry in Chicago, an adjunct clinical assistant professor at the University of Michigan in the Department of Periodontics and Oral Medicine, and a fellow in both the American and International College of Dentists. He has published over 40 scientific papers in peer-reviewed journals and has authored 8 chapters in textbooks on subjects related to guided implantology, CT and CBCT diagnostics, and surgically facilitated orthodontic therapy. George is a past president of the Illinois Society of Periodontists and currently serves on the American Academy of Periodontology Board of Trustees. He just recently released an amazing textbook titled Surgically Facilitated Orthodontic Therapy, an Interdisciplinary Approach, and we'll be talking about that book and some of the contents therein during the show. George maintains a private practice in Oak Brook Terrace and Glenview, Illinois, where he limits his practice to periodontology, dental implant surgery, bone reconstruction, and tissue engineering surgery. Some of the other things we're going to discuss on today's show include the importance of taking the time to properly diagnose and treatment plan your patients, including the value of CBCT for routine diagnostic imaging, the need to educate your patients to help them share a vision for your goals and objectives for their treatment, what surgically facilitated orthodontic treatment is and how it can be beneficial both from a periodontal and orthodontic standpoint, new concepts in tissue engineering and guided bone augmentation, some of the obstacles that many specialists and non-specialists face in the field of dentistry when it comes to implementing some of the more advanced techniques and technologies, and much, much more. So without further ado, let's get on to today's episode with Dr. George Mandelaris. Enjoy the show, everybody. Welcome to the Doc Podcast, George.
Yeah, thanks for having me. It's great to be with you.
I'm so happy to have you here. We got to meet in January, so a few months back at the Winds of Change in St. Louis, and got to hear your awesome lecture. And after hearing you speak, I said, I want to have this guy on and pick his brain because you're just a wealth of information on these topics, and I'm really excited to dive into them with you today. Before we go down that path and start to get a little more in detail on the science side and the clinical side, tell me about your journey, how you got to this point, what brought you to be where you are today.
Yeah. Oh, by the way, I've developed a pretty nice relationship with Reza and Dr. Moshiri, and we're trying to even elevate Winds of Change even more. So next year, end of January, it's going to be here in Chicago, and it's going to be actually like a cadaver course where it's going to even be dialed up even more.
Wow, so that's pretty cool. So, nice breaking news there. That's great.
Yeah, it'll be pretty cool. So my journey, I'm originally from Flint, Michigan. I was born in the Detroit area, but they're young, and then my mom's from there. So I went to undergrad in dental school at the University of Michigan, and along the way, you meet people that tend to influence your life when you're young. Mm-hmm. And I, at the time, was influenced pretty heavily by Hamle Wong and Bob O'Neill. Mm. Bob was the program director of the Periodontics department at Michigan. Hamle was a brand new faculty there, and he took me under his wing. We did some research projects, and I always really liked the surgical side of dentistry, but what I really loved about periodontics was, which I got kind of immersed in just by doing some side jobs in the dental school and the grad perio department where I was always hanging around, just finding how science-driven it was, the biology of it, and then there was also surgery. So I was just so intrigued with it, and just the relationships that I had made with some of the mentors that I had, and just seeing how other faculty members would consult with them. And I thought, these are people that I would aspire to be like, and I just gravitated towards that specialty. It just felt right, and it was. So when I graduated from dental school, Hamle said, you can come here if you want, but you've been here in Ann Arbor a long time, and I think it's good for you to get a different perspective. So he said, I was trained at Case Western by this guy, Henry Greenwell. Henry has started a program that's been out for like 5 years, but it's a really good clinical program, and I think you'd really like to learn from him. And so I went down, I interviewed, and Henry gave me a position, and I just never looked back. So I went to the University of Louisville. I got a Master of Science degree there because it was a program where you did 3 years, and then you also had to do a research project and defend a thesis and so forth. And then when I finished, I thought, I'm single, I can go anywhere, I want to conquer the world. And I was just very enthused by people that I would see at meetings like Massimo Simeon or Oded Bahad, or these guys that would do just these amazing cases. And I thought, I really would like to learn this and I like to be at that level, but I'm not anywhere near the experience. I just, how do I get there? And there happened to have an opportunity. There was a ad in the AAP, and the positions wanted. There was a practice in the Chicagoland area that was looking for a person. So I thought, I'm going to move back. I'll go to Chicago. It's close to my home. And the practice that was looking for an associate was started by a guy named Alan Rosenfeld. Alan went to perio at the University of Pennsylvania in the heyday, so from 75 to 77. So he was trained by D. Walter Cohen, Jay Siebert, Mort Amsterdam, all the kind of the gods of perio pros and ortho at the time. So Alan was looking to bring somebody in. So I had interviewed with Alan, and I just knew that even if Chicago doesn't work out for me, I'm going to learn a lot from this guy. So it felt safe. It felt comfortable. It felt like a great learning opportunity for me. And he was very much a teacher at heart, and he wanted to teach, and I wanted to learn. And I had no obstacles to learning. So I started in the practice. I did hygiene for the first year. I think I did like one connected graph. I was doing anything. And again, it was really just more of an opportunity to learn. So one interesting thing about the practice was that Alan and Rick had gotten involved in implants very early. And basically their training was in Texas by Gil Triplett and Steve Harrell. So when they went to take these courses, they said, geez, I've taken this course for a couple of days. I don't know how we're supposed to do this in our own office. And Alan had cold called Gil Triplett, say, hey, would you be interested in coming to our office to learn for a couple of days, to help us? And he said, yeah, I'd love to. In fact, I'm coming up for an AMIS conference or a meeting, and it's in Rosemont. So I'll come over and hang out with you guys for a couple of days. Wow. When Alan was taking him back to the airport, he said, Dr. Triplett, why would you come and spend a couple of days with periodontists? You don't know us. And he said, I've never seen what my teachings became from the students that took courses from me. And so that started a relationship with Alan and Gil Triplett, who was at Baylor at the time, and gave them a lot of confidence to be doing more and more implants in the late 80s. Well, they also got involved in CT scans. So when they were doing CT scans, because our office was at a level 1 trauma center, a hospital in the Chicagoland area. And so they were basically using CT scans to evaluate and diagnose cases before they would operate on them. And they realized that the problem is there's no teeth in these CT scans. So this translated into, we need to do a diagnostic wax up. We need to create these barium templates, which then we can scan patients on, and we can see where the teeth are, and we can relate that to the regional anatomy. And we can start to determine, is there compatibility between the two? Which then led to software programs like Simplant that they got involved with very early on. So they kind of coined the term the optimal final tooth position, and they could relate it back to implants. So when I started, I was exposed to all this and the Simplant planning, but the problem was you couldn't plan in 3D. So you could plan in 2D, but you can't plan in 3D. And there weren't guides available back then, Mike. So there was always this song and dance between why are you radiating patients? Because if you were a good surgeon, you would just open the flaps and put the implants in, right? I mean, so we were pretty chastised in the area, you're radiating patients, you're glorified hygienists, you don't know what you're doing, you're not real surgeons, because if you did, you wouldn't need all this stuff, right?
Interesting,
so
okay.
How things evolve. So then fast forward a few years and surgical guides become available, right? But they were pilot guides, right? And 3D started becoming available in the software program. So when you move something into 2D, you could actually see it in the 3D moved as well. Align all these things. And now the performance standards started to become more standardized because you didn't have to be like a Pavarotti of surgery to have an excellent result, right? You kind of standardize your results because if you put the time into the planning, the guides, you'd be able to execute that plan more accurately than if you had to do things freehand. And so the way we would do it is we would open flaps, we would put the guides on, we'd do our drilling, put our pins in, and we would still have the old-fashioned guides, the template guides, and we would put that on the teeth and see, is this right? Are the guide pins coming where the teeth should be? Is this correct? And, you could always move the guide a little bit to make sure that it was coming through the middle of the teeth rather than the engraving. But we took all these little baby steps, and then you went from pilot guides to...
Would that have been like late 90s around
that? That would have been like early 2000s.
Early 2000s, okay.
Very early. So the CBCT wasn't even available. So we would send patients to this medical imaging company in Northbrook who would do medical CT scans, and then they had this implant master software program. Okay. And then they would segment everything and then send it to us, and then we would plan it, and we would send it to either Belgium at the time early, and then they had a site in Glen Burnie, Maryland, and then they would be making guides for us and so forth. And then you had fully guided systems, and it was when Alan went to this NYU program where he was presenting on guided surgery, but at the time it was just like sequential step guides. It was 2 millimeter drill, then you took that guide off, then you put a 3 millimeter, it's just pilot guide for a 3 millimeter guide, and then took that guide off and you put a 4.3, and then you put the implants in all freehand. Well, there was this guy presenting at this meeting by the name of Philippe Tardieu, and Philippe was a French, he's originally from Algeria, but he was a French, I guess kind of quasi-periodontist, implantologist. And he and this guy, Luc Vrielink, who was a craniofacial surgeon, came up with the guided system that we know today. Like basically, they introduced what he called the regulator, but what we know as prolongation. Okay. So they kind of came up with like, how do you make one guide and be able to place implants through this one guide so you don't have to keep changing things out, and you can put the implant in guided as well. So they came up with, he called the X factor or the regulator. So you could have a guide that would be in different vertical heights that would allow you to do all the drilling in one guide and put the implants in. And then we went to all these perio meetings and nobody would listen to us until one year finally Red and White comes out. It's the Nobel guide. And then that just transformed really everything. And then you went from guided surgery to now a stackable guide where it was like you could do bone reduction, which you could do in the past as well. But then you could have a prosthesis made ahead of time. And then you could load everything ahead of time. I mean, we used to gut out dentures and then lute that together with titanium cylinders. And it was not really a very minimally invasive or really elegant type of procedure. But at the time, it was very novel and very forward thinking because you were able to do things more minimally invasive. You could do flapless. But I look back today and I think all the errors, and I think about doing some of that stuff flapless the way we did it. And I think, God, my gosh, we probably shouldn't have done what we did, but we didn't have the studies to know what are the errors if you do it with the tooth-supported guide, a bone-supported guide. So we got to this point in periodontics, and then, I just thought to myself, is this it? And at our core, it's all about saving teeth, right? I mean, it's an interdisciplinary dentistry, which was really my passion. I just loved developing relationships with just restorative dentists, prosthodontists, orthodontists. I just loved the relationship building. And one day, just a savant restorative dentist comes up to me, Brian Vent, saying, you need to start learning about corticotomy surgery because I think this is the future of periodontics. And I said, well, what's that? Where do I learn this? He said, well, there's a guy I've known for a while. He's in the Restorative and Aesthetics Academy with me by the name of Rick Robley. And Rick does some incredible stuff with this Scotty Boulding in Fayetteville, Arkansas, which you got to check out. So we went, I saw what he was doing, and I was like, this is incredible. This is amazing. But I was having a hard time finding any orthodontist that would, help out, that would go along with it. Because all they knew about was Wilcodontics. And Wilcodontics, I stand on their shoulders because I think they're giants. But their message was move teeth fast. And no orthodontist is going to refer to move teeth fast. At least back then, they were like, we don't need this.
Right, for something that invasive to cut treatment time in half. Right, yep. Understand that completely.
So we didn't think about phenotype change. Airway wasn't even on the radar, Mike. I mean, it wasn't even who was talking about airway. And so I happened to have this patient who had a cleft lip, cleft palate. And she was very compensated, recession. And I was working with an orthodontist who was really open-minded, and he was in tune with bone biology, had a PhD in bone biology. He was a former chairman at Northwestern. And I said, hey, Dave, I've got this patient who's very compensated. I wasn't using those words at the time, by the way. The teeth are in the wrong spot.
Yeah.
And I was
no good bone,
like,
right?
this recession treatment, which means she probably doesn't have a lot of bone. Would you be interested in doing this like corticotomy with me? He said, yeah, I'll give it a shot. So we went to his office with the patient, with her father, and we explained what this was. And we thought, he said, maybe this might be something that could help, because at the time he said, I've always had a very difficult time managing these cleft patients because she had a tongue flap, and like we can't move them. They're very difficult patients to move the teeth properly in an orthodontic standpoint. And with his biology mind, he thought, what if we create a demineralized bone matrix with releasing all the fibers? Maybe I could move the teeth without this rubber band effect. Maybe I could be successful. And so we thought, okay, we'll give it a shot. So we did the surgery. And when I opened the flaps, I thought, oh my God, there's dehiscences everywhere. I'm like, he's going to expand this patient and blow these teeth out of the bone where there already is zero bone. And so all I could think of is, I'm going to throw the kitchen sink of periodontal regeneration at this poor girl. Emdogain on the root surfaces, every bone graft possible. I put a connective tissue graft in there. I put PRF in there. I put everything I could put in there. And I was like, I just hope she doesn't lose her teeth. And lo and behold, at 2 weeks, he started engaging heavier arch wires and using some cross arch elastics. And I documented this every 2 weeks, and he was just expanding, and he kept calling me. He's like, I can't believe this. I can't believe our teeth are moving. It's crazy. So I got to 4 months and I thought, I got to rescan her. We got to see what's going on. So I re-imaged her. And because I had this relationship with Implant at the time, I said, hey guys, can you take the 2 scans that we had and somehow cross-reference them and see if anything, like what's happening. Sure. And so they used a cranial reference point. They imaged the 2 softwares together, and it was crazy because you could see a very kind of, compensated arch form to now one that was very broad. And then we could see the bone. And certainly there was some tipping of some of the teeth, but you saw a distinct translation of some of these teeth. That was incredible. And there was bone on the imaging. So it was an incredible result that really was a seminal moment that was like, hey, there's something to this. And then it got to be where she got so excited with what was happening because she could see the facial changes that she said, I want to correct the cleft. And we went from a situation where the whole thing got started because I had treated her like probably 5 to 8 years ago by a referral from a different dentist in the North Shore. And I treated her with a connective tissue graft, which basically, receded. Now, fast forward, whatever, 7 years later, more teeth had receded, but she had moved to a different area in Chicago. A different dentist referred her back to me, and she's like, this is the same guy that treated this. Like, why do you want me to go back there? So now she had more recession, and we thought it was an endodontically treated anterior tooth. And originally, the referral was to like erupt the tooth, see if you can manage this tooth for an implant. Well, she had it cleft at number 10, so we were going to erupt number 9, extract it, put an implant, and cantilever the lateral. And then we started thinking about all these other issues. And 15 years later, she still has the anterior tooth. We were able to save that by converting the phenotype. And then she ended up correcting her cleft because she really got excited by the changes that were happening. And while there has been some relapse, it's been, I would say, really quite limited in terms of what we were able to accomplish at that point. And so that's kind of started the whole process that we needed to really learn more on what was going on and how could we apply it to different patients and so forth. And I thought to myself initially, Mike, this is going to be the future of the practice. I'm going to get so many referrals from orthodontists for this stuff because once I start showing this, they're going to start flooding the office. And never happened, right? It never, ever happened. But what would happen is patients would come into the office with recession referrals. And invariably, these patients with recession would have a malocclusion. So I would say, you have this recession-based problem, but you also have a malocclusion. It would really be beneficial if we treated your bite with orthodontics. And because there's probably a deficiency of bone, we can maybe do this a little differently if you're open to it. So it took a lot of educating of the patient. And that's kind of how more of this built. And At the time, I knew that I needed to learn more because it started building from smaller cases to more full mouth cases to then the flaps are different and so forth. And at the same time, I was trying to learn GBR techniques because those are starting to become more and more a part of the periodontal profession, right? So I remember this relationship with going back to Alan years ago of when he started with implants. And Alan went to this conference and he said, I just think I heard the smartest guy I've ever heard on any podium, Dan Spagnoli, who was talking about tissue engineering. And so I had this complex case. I called Dan and I said, hey, Dr. Spagnoli, this is Dr. Mandelaris calling you from Chicago, trying to at least keep on the phone. And I said, I have this patient I'd really like to learn from you. I know of your work with BMP, and would you be willing to come to Chicago and work with me on this case? And he said, yes. And I just about fell off my chair. And I said, well, I just want you to know I'm not an oral surgeon. But he was like almost offended that I even said that, because he said to me, implants have been born on the backs of oral surgeons and periodontists for 20 to 30 years, and we need to help each other continue to improve patient care. And he said, I'm going to come up and help you with this case, and we're going to do this tissue engineering case together. So it has built this relationship with Dan, and I would send patients to him because I would see very complex cases that I wasn't quite ready to handle. And from that relationship, I understood how an oral surgeon sees patients from the face, orthodontics. And then he was able to teach me what an oral surgeon, like how a flap was. So when we were operating together, he would be like, this is a perio flap. You got to open that more. I was like, oh my God, I'm going to hit something. Don't worry about it. Not gonna hit anything. Just keep going. And so it was really an eye-opening experience for me. And it was that relationship build that kind of helped evolve my surgical skills to help maximize the GBR principles. But then it also built over to the SFOT because it is a large surgery. So it is kind of a, at the core, it is an oral surgery, I guess, procedure. But it's the finesse of opening and closing that periodontics brings. And it's the value of regenerating bone around the teeth. You're ultimately displacing the teeth, but these concepts of periodontal regeneration, bone regeneration, with gaining excellent pink aesthetics and so forth, is how all this kind of evolved. And then airway starts to come into the play. And then we add cone beams into the office. And now everything starts to expand. So that's kind of how it just continued to build. And that led to a number of publications that led to doing some courses here in the Chicagoland area that led to the book that we published. But that was like a 6-year project that I will never do again. It will not be a volume 2, Mike. It was like too much, but it was a labor of love, and it was some really great people that were able to get behind us to do it. So I'm proud of it. And I think like most of these things, whether it's putting a presentation together or a paper or anything like that, you kind of put yourself through this process where you do make yourself better because you learn more. I had to learn, how does an orthodontist look at this? How does an oral surgeon look at this? How does a pros look at this? Because there's a need for it in each discipline, and each discipline looks at it differently, and what they value from it is different. And so if you and I are working together, I would be using words like compensation, you need class 2 elastics, class 3 mechanics. And then I could relate how that's going to impact the perio, so I couldn't talk like that 15 years ago. You guys were very siloed. You were like, nobody even learned ortho in dental school.
Right.
Like, I remember in Michigan, we didn't really learn any ortho, very little. You learned how to refer to ortho. You didn't know what they were doing, why they were doing it. And that's unfortunate. But a lot of that has changed today because of technology, because of the transparency of imaging and all that. Yeah. So it's an exciting time to be in practice. And I think what we can do for patients is beyond what we ever thought we could do, when I started, for sure.
Without a doubt. Yeah. And that's why I love hearing people's stories, because if people just know who you are, they hear you speak, you can easily think, well, he just knows these things. And you have been on such a journey. Yeah. And what I love about it is it's clear that you are literally, and I'm not saying that it's cliche, but you are a lifelong learner. And I find the people who push the envelope the most and achieve the most for their patients and for the profession are the people who are willing to push the envelope. And that's where a lot of times I'm hard on some of my academic and orthodontic colleagues, and I don't mean it in a adversarial way. I just try to say you need to keep pushing. And I feel like sometimes in academia, they're much more hesitant to do that. All that being said, we need academia as our foundation and our bedrock to start to give us the ability and the knowledge to practice in our profession and in our specialty. We also need private practice and people like yourself who are willing to push the envelope responsibly, using knowledge and using science and using evidence and using data to apply those fundamental concepts clinically in a way that can then have an amazing impact on patient care and advance the overall patient care. And really, George, that is a la Sackett of evidence basis and evidence-based medicine. That is evidence basis. What you just described is evidence basis. It is literally evidence-based medicine / dentistry. Those three parts, right? The academic side, the studies, and it doesn't have to be randomized controlled trials or systematic reviews, but sound data, and clinical practice is the second one, and the third one being patient values and desires. And that's what you said. In all of the things you just described, you described many times all three of those areas led to your decision-making process. And there was actually an article, I think it was like 2002 British Medical Journal, but there was an article after Sackett passed, which I think was 2015, saying how evidence-based medicine had been hijacked. And it had been hijacked to mean it had to be a particular study done in a particular way. And that's not it. It's what you just described. Yeah. Right? I mean, it's constantly learning and meeting and challenging and talking and being honest with your patients that this is something a little out of bounds, but there's sound science behind it. So when you were mentioning phenotypic change, SFOT, talk a little bit about what these things are and as they exist today in your hands or in the profession, how is that changing patient care?
Yeah, I have to go back because everybody that I had surrounded myself with was always very curious, but they were substantially older than me, but they're always curious to learn. And they were asking me, like, they're trying to learn from me, like I had something to give them, which, it's like, okay, I'll just, whatever I can share with you, I will. But I think that curiosity is very key for having a successful future.
Yes.
And people will gravitate around you if you remain curious and you have what Alan always called a periodontal conscious, but a biologic compass, right?
Love that.
So periodontal conscious, but a biologic compass. Failures and complications are going to happen. That's just part of medicine, part of dentistry. It's part of treating complex cases. That's not the problem. The problem is when you get off where your conscious is and how your compass is headed. So going back to these cases early, I remember looking at them going, oh my God, I've never seen people get expanded, but their periodontium is just like becoming more robust. Where the orthodontist was like, well, look at the class one, class one. I wasn't paying any attention to the teeth. I was just looking at the gums, like going, wow, this looks amazing. So I was like appreciating what we would call the phenotype, but I didn't know the language back then. And it led to some opportunities at the AAP and kind of showing these cases, which then evolved into a consensus where we started with CBCT. And myself and Todd Shire were the co-chairs of the first ever Best Evidence Consensus Workshop at the AAP, because we were one of the last specialties to actually endorse CBCT imaging as a modality for implants and then perio and then its role in orthodontics. And so we didn't, because the perio is very evidence driven, right? It's very science driven. And so the problem was there wasn't enough studies to have a systematic review, a meta-analysis, things like that. And so it was kind of like poo-pooed. But everybody knew, like, you need this information. So Ken Foreman, at the time he was the editor of J. Perry, he said, we need to form these best evidence models, which are part expert opinion and part what's the best evidence that we do have, that we don't have enough to say it's a systematic review, but we can at least put some guidelines in place for the clinician where there isn't enough literature, but we can help guide them to make the right decisions based on the available data that is out there.
Yes. So which is literally when you read, that is evidence basis. That is like, that's it, right? Exactly. Yeah.
It was best evidence consensus, right? So we had the first one in Chicago And Todd and I kind of chaired it. And then that evolved to one on biologics. It evolved to one on lasers. We also had one eventually on the phenotype. And so basically periodontal phenotype, it's really made up of two components. So you've got the periodontal phenotype, but really what you're talking about is the gingival phenotype, which essentially can be broken down into a keratinized tissue width, 2 millimeters or less, and gingival thickness. Can you see the millimeter or more? Can you see a probe through the gingiva or not? So thick or thin. And then the other part of it is the bone morphotype. And if we look at all the studies, Boozer and Nozario, all these others, they basically say, look, normal human anatomy is about 1 millimeter of facial bone thickness from premolar to premolar. That's kind of like normal. Most people have less than 1 millimeter of facial bone thickness. But if we say 1 millimeter, it's like our norm, less than that's thin and more than that is thick. Then so that's kind of where periodontal phenotype got its genesis. And then if you can apply those principles to treatment planning, then you can start to make some decisions like, well, are we going to make the phenotype worse or better if we apply certain principles? So that's kind of how that started. Okay. I also was working with a buddy of mine who was very big into SureSmile. And when I saw SureSmile, I thought, not to like name things, but I saw aligners. I always saw the planning as like, it's just like cartoons. It's like you're just moving the crowns and the gums around. And that's not really what I see. I don't see you expanding and the gums like stay thick and get better. I wasn't seeing that. But when I saw SureSmile, because that wasn't planning with the understanding of the impact of tooth movement on the dental alveolar complex wasn't something we were able to see because it was superficial. But with SureSmile, you were able to see the impact of tooth movement on the dental alveolar complex, and you could see all the roots that would be exceeding the boundary conditions. Now, some of it might be very limited, in which case you would say, hey, the x-rays are overestimating the bone loss that's here. And that would be appreciated. But you see the root get way out, then from a risk assessment standpoint, like this is going to put this patient into potentially jeopardy, and augmenting the dental alveolar bone phenotype could be something very valuable, not just to move the teeth fast, but to change the regional anatomy. And those cases really those cases were obvious when patients had crowding. A lot of crowding.
Sure.
And then what would happen too is moms would come in with their kids, and moms would say, well, I had premolars taken out and I don't like how I look. I feel like I'm too narrow and I don't have enough room in my mouth for my tongue, and I don't want that for my daughter. So if we can have something different where we can expand and not take teeth out, I would like to try that. And it was interesting. I would hear these stories from patients. So you can apply that to some of these cases. But yeah, that's where the best evidence consensus, kind of how that evolved. I had some roles in those conferences. So now you're starting to see not just the papers on the vulnerability of the facial bone thickness, but also phenotype conversion. And then we have 2 papers that are coming out in Periodontics Restorative Dentistry talking about phenotype-driven treatment planning. So using the gingival phenotype and bone morphotype to see what you have, you can then say, okay, this dentition currently is intact, is susceptible, or is deficient based on, and so you have to go over each tooth and say, based on this anatomy and based on how this patient presents, if we do that, that may mildly, moderately, or severely exacerbate periodontium. So if it's a patient who has an intact periodontium and phenotype, and maybe the tooth movement's going to be pretty limited, maybe no treatment at all is needed. Or perhaps a connective tissue graft is needed if it's moderate exacerbation. But if it's a severe exacerbation, then maybe is somebody that could really benefit from a corticotomy and dental alveolar decortication and augmentation procedures. So I think with the expansion of aligner technology, and then some other unfortunate treatment that people have been subjected to, which is really very poorly evidence-based, I just started to get involved with patients that were really, they were led to believe that certain types of orthodontic mechanics would not exceed limits, that you could cure airway problems, that you didn't need orthodontic surgery. That was, you could resolve people's discrepancies by slow movements and these acronyms. Anytime I hear an acronym, it's like, okay, there's something.
The radar goes up a little bit. Yep.
There's something behind this. So I would just be a little leery of that. But the acronym coded plans if you really looked at what was happening at a foundation level, there were really problems. And a lot of these people were blowing teeth out, getting root resorption, and really unfortunate. I always found it so strange because it's so difficult to get into dental school. You have to be a pretty bright person to get into dental school and to get through it. I mean, you can't be a dummy. But then you have this intellectual person, and then they just get roped into these courses that they like lose their brain. It's just, there are certain things that are disappointing, I guess I would say. That's why I think transparency is really key. And that's where, as we're evolving with imaging technology, and you can show me, like if you come to me and say, look, this is the case I'm going to do, this is the imaging, look at this, how I've decompensated the patient. I really need you to do this here, or I don't need corticotomy, and let me show you why. That's very obvious. But before, historically, it was just, I have a class 2 patient, we're going to take some teeth out, this is what we're going to do. And because most of the profession doesn't, in periodontics, we don't really understand, we didn't know orthodontics, it was like, okay, well, that's fine. And then you would see a periodontal annuity patient, for recession problems, and then they don't have bone. Sometimes the connective tissue grafts are not working well because they're overly proclined or they're camouflaged, which is then difficult to handle the perio problems with that. So now the way I always start to look at the patient is not just in terms of like their face, are they canted, do they have a shift? Like I'm looking at these things, but the imaging is so important, and it's so important for us not just to look at a small field of view, but a larger field of view, because you can glean the information you need from it perio-wise, implants, periodontal disease, intrabony defects. But you can start to ask the big question is, how is this patient presenting to me? Are they where are their deficiencies and their discrepancies? They're coming with a mandibular plane angle like this. They have a growth pattern with an SN to GOG angle of like 44 degrees. That's a vertical grower. Man, that is a tough patient for the orthodontist. You start to appreciate how difficult it is to treat these patients orthodontically. And when you understand what they're now up against, then you start to have more compassion. You realize, hey, there's some things now that I can maybe do to help you have an even more successful result. And that's where these are the barriers we have to kind of break down, but it has to be through like relationship building. It has to be through transparency, and it has to be like, I understand what you see and where I think you're going to have difficulty.
And the diagnostics and there's a whole portion of your book dedicated to the part 2 is like 6 chapters that are on the patient assessment, co-discovery, diagnosis, and treatment planning. I feel like, and this is something I say often on this show and when I lecture and speak, I feel like we've done a disservice in orthodontics to the overall profession and the patient. And I was guilty of this at points in my career, and I had to think about things, and I was able to make some changes in that. But I went down that path and fell into the trap a little bit too of faster, right? We are running these very busy practices, and consultants come in and they're trying to teach us how we can see more patients in a day in less time. And the low-hanging fruit that we tend to try to cut is the time in the consult room doing our diagnostics, right? Because we're told by a lot of consultants, well, you're making your money in the clinic. I say the exact opposite. Not only are you making your money in the consult room, but you're doing your best work in the consult room, right? And because when you're looking at those records thoroughly and taking the time to get to know your patient, right, in that co-discovery process, which I had Paul Henney on the show, and he was talking about the Bob Barkley concept and the Pankey concepts of getting to know your patient, understand what they're coming to you with, or the parents of the child, as the case may be in ortho sometimes, really performing a thorough patient assessment, looking through all of these other parameters, and then figuring out which of your medical and or dental colleagues you need to work with for this patient. That, to me, is the top tier of care that we all need to be striving for. The tough part is it takes more time and it's typically not directly reimbursed time, right? So for people who are all about just the bottom line, or some of these corporate entities where it's a procedure-based business model. I mean, all of us to some extent are procedure-based, but when you get into some avenues, and it literally is all based on procedures. And George, we've seen what it's done to the medical community. Once they started taking general physicians and making it about 6-minute visits and X number a day, any of us who has been to a standard physician visit, annual visit, can tell that it is not what it used to be decades ago. So I love that you highlighted that. And I want to call that out to say to our colleagues, whatever discipline you're in, general, specialty, the key is that diagnosis and treatment planning and building the plan. And I feel when you do that, and then I want to hear your thoughts on this as well, I found in my experience, and when I teach residents and teach other docs, when you do that, your cases go so much better in the clinic that you end up, it's a delayed gratification of sorts, and it's not a direct ROI in that sense, but the indirect ROI, when in the ortho world, your cases are taking half the time and a third of the number of visits, and the results are better than if you just are all about, well, look in the mouth real quick. I mean, we would get second opinions all the time, and the patients would comment and say, this experience has been so different. We're looking at 3D images and talking them through all this. And they're like, I saw another doc. They walked in, took a mirror, looked in my mouth, said this to their person on their staff, and walked out. And I'm not saying all orthodontists do that. What I'm saying is it is all too common in the profession. I really feel that needs to change.
Yeah, I mean, ortho in particular, they are the earliest caretakers of the periodontia, right? They have the ability to change the trajectory of a patient's life.
I'm so glad you said that. I remember. Yes. Go ahead.
They really do. And, I'm not an airway dentist, right? But I am very airway conscious. And I think that specialty is so exciting right now. They have such power to change lives. It's incredible. It brings me back to Dan. We used to go down. He became the chairman of Oral MFS at LSU, and he would have us down, and it was great to kind of get that experience with him. And I just remember one time, Alan and I went down there, and I said, you know what, perio is changing. What we're doing is so different. We can't be doing these surgeries in these small cubicles anymore. We need to create like an operating room in our office that is also accredited. So we put in operating rooms, but the office was also, as I went through that process, I wanted it to be accredited as an office-based surgery center through the AAAHC. So the office became accredited, and we had an operating room that was dedicated for these procedures that could also handle more advanced anesthesia, because moderate sedation, certain patients respond, some don't, and then others that were doing more complex care, they just need to be in the hands of a good dental anesthesiologist so that you can focus on just doing the surgery that is complicated enough. And I just remember Alan and I and Dan standing around, and I was telling Dan my vision, and he was like, Alan just said, George, I really don't know why we need to do all this. This is just too expensive. We don't need to do this. And Alan was a very cutting person. Like, the way in which he uses words is very powerful. And he looked at him in the eye and said, well, I guess it just depends at what level you want to practice. And to say that to people like us, it was like, okay, game on. And that's all he had to say, because at what level do you want to practice? And that goes with the diagnostics. That doesn't mean you have to have a $2 million office built out. It just means like you do have to spend the time. It's what level do you want to take care of patients at? And that's always stuck with me. And so every time I see somebody for a limited exam, we have to see people for a limited exam. I get that. But, when we do it consistently, you kind of create this disservice to the patient, particularly when you know what you know, right? It's hard to unsee what you know. And I just feel like I need to do right by my patients, by the people that are entrusting those patients to me when they refer them to me. I want them to know they're coming to see George. He's going to look at you a certain way. Even if he needs just crown lengthening or something, he's going to look at a patient a certain way so that we do the best thing for that patient. Not like we're going to just try to schedule him for surgery immediately just to fill the schedule, but it's more just like making sure that we really look at this patient thoroughly. And what I've really been most excited about is the early intervention, starting to have an influence on some of the orthos that I've been able to work with now, who are looking at patients very much earlier, looking at nasal breathing, looking at the nasal maxillary complex, the impact of MARPE, which is transformative, and really thinking about that. Because to me, it is exposed more on orthodontics. More patients really need orthodontics, looking at joints, looking at all these things, and it makes me a better diagnostician and a better referral to the orthodontist, really, or in the oral surgeon. Because I never really thought about orthodontics that much. It was always like, oh my God, I hope you don't need that. That's how we were starting in dental school, right? Like, oh God, might as well have cancer. But now it's just when you can see some of the really skilled orthodontic surgeons, Mike Gutson, Reza Movahed, Rob Borelli, Brian Shaw, those people that are on that high level, you see what they can do for patients, and it is transformative. And to be able to be a part of an interdisciplinary plan like that has an impact on a patient's well-being, you can't put a price on it. And with the DSO models now taking form, when patients pay a fee-for-service practice, they're going to expect a certain level.
Yes.
Especially if they're having things done a second or the third time, right? They expect you to kind of comb through that data set. They expect you to really put the time into thinking about their care, because if you don't, it's only gonna downgrade our profession and what we can do for patients, right? We're not going to elevate our care if we don't spend the time combing through everything and really thinking through things.
Yeah.
The billboard signs and the implant centers in a day and all that, that's all great, but I can't tell you how many immediate implants I see on Instagram and this and that with a compensated occlusion, with probably distracted condyles, with all this stuff that, why do we not spend the time to think through this and build a relationship with the patient and at least advise them of risk? And if they don't want to heed it, fine. Right. Let's do the single tooth stuff. Right. No problem. But don't tell me I haven't told you what the risk is, and you assume that risk now. Yeah.
Yeah, and that is informed consent. And I completely agree that working together and having this comprehensive approach, while more challenging in some ways, once you get it and start doing it, it's just tremendously valuable. And I really feel it's what's going to take our entire profession of dentistry in each of our respective specialties to the next level by having this type of approach. When you said about what we can do to help the tissue health, especially young, I'm so glad you brought that up. And I wasn't actually thinking of saying this to you, but now that you triggered that in my mind, I can't tell you, George, how many cases that I go in and I do my early interceptive phase 1 on, and let's just say 6, 7, 8 years old. And I'm going in, and I know now we're even thinking about and doing things to go in earlier than that, but let's just take those patients. So their permanent incisors are erupting. And especially on the lower, you'll see if the centrals start to come in and maybe they're crossed or overlapped a little bit. So one ends up getting pushed a little further labially. And then in these crowded, narrow, arched, insufficient tongue space, oftentimes mouth breathing, snoring patients, you see the laterals coming in lingual. And I know there's some incisor liability in all patients, but there's 2-3 millimeters of space maybe between the central and the primary cuspid, right? We are really, really tight. So the laterals are coming in lingual, and then they start to push labially on those two centrals. And you'll see this kid present, and you see this clefting and loss of attachment on the lower centrals. When I would go in, and my protocol is using braces and wires for it, but regardless of how you do it, when you go in and expand and develop these arches and normalize the anatomy and approach the etiology of it, which we'll talk more in a second about CBCT and the transverse side, but when you're able to detect this narrow mandibular arch and narrow maxilla, and you can upgrade those mandibular teeth and expand the maxilla, when you start to make the arch perimeter and the space and then align those lower and upper incisors and normalize their inclinations in the bone, George, the periodontium heals on its own. Like I could show you before and afters where you look at this kid and you're like, oh my God, that kid's a connective tissue graft. I mean, there's just no way, as they're not going to need that later in life. And at the end of phase 1, a year, 14 months later, you would never even know that there was ever an issue. So why in ortho are we not talking more about that side? Because take the airway side even out of it. Just the overall developing the bone and normalizing the anatomy enough that the teeth erupt into a better position, and the incisors that have erupted in a bad position aren't left out there, hanging out there to have all these negative consequences with the periodontium. In your opinion, speaking with orthos and knowing as much as you do about it now, why don't we talk about that more?
That's why your podcast and what you're doing for our profession is so incredibly important and impactful. You're changing what we do for the better. But, Melvin Moss used to say, bones don't grow, bones are grown, right? And so you have the chance at an early age to intercept these patients, shrink their tonsils, improve their arch forms. And so the younger kids they're just much more adaptable, right? And so particularly when you have like the maxilla and trimembranous bone, endochondral bone is very hard to, when you get older, it's like a Starling resistor. You move the teeth out, the bone is not going to adapt very well. It's not going to expand and and it's not all that plastic. But in the maxilla, probably maybe a little more so. But when you're dealing with a young kid, you have the chance to really manage that plasticity a little bit better, and you can make a big difference. So it goes back to those Slick Van Ardale days, those pen days of getting the tooth centered in the bone with a good intercisal angle relationship. And when you do that, you're going to have a very robust periodontium. You're going to have a healthy, patient, and probably very little need. That's the power of what you can do with early intervention.
Yeah.
And
yeah, it's amazing. On the CBCT side, and I'm going to keep asking you all the problems of the orthodontic profession. That certainly isn't my intent in this, because I'm asking you more just from an outsider looking in as a part of our profession, but also in a separate specialty. And you've interacted with a lot of orthodontists, so you're not immersed in it to the same extent. So you have a little bit different viewpoint, a little better perspective than maybe some of us who are head down and entrenched in it. Why have you found that so many orthodontists are still so resistant to making CBCT a routine part of our practices? Because in 2014, once low-dose came out, I put a low-dose ICAT Flex in my practice over a decade ago, and it transformed, not just airway, yes, on the airway side, beyond that, the periodontal side, the bone stability side, the tooth inclination side, just understanding and appreciating the transverse, the compensations that you've been talking so nicely about that happen over time. Why is this still a thing? Why are we still arguing about this?
Well, I think probably the training programs depends on whether or not that's a part of your training program. Alan always used to tell me, humans don't make good lab animals. It's hard to change human behavior.
Yeah, that's true.
Right? It's hard to change human behavior. Yeah. And it takes a special person, particularly, look, when you have a busy orthodontic practice and you're doing pretty good and you're getting pretty good outcomes, if you don't have that inner drive to continue to be curious and to learn more, and you're kind of like okay with being stagnant, then that may be kind of where you're at.
Yeah.
But I think there really isn't a good reason to not embrace CBCT imaging, but it goes back to the time and money thing. Yeah. It takes time to get at because mom and dad probably didn't have scans when they were getting ortho, when they were like our age. So you have to spend the time of educating them on, let me explain to you, this is a different x-ray system, and let them know that the radiation risk probably when you had orthodontics was 10 times what,
even
what your
right,
kid
even a non-low dose, right? Because the low dose I used, we were taking them, the effective dose per the 2013 Ludlow article in AJODO, the effective dose was like 17.5 microsieverts. With the image, I took a full Ceph view, 16 by 13, full 3D. Their Quick Scan Plus is what ICAT called it. Since then, there's been other machines that have come out with comparable products for less radiation. So I was taking full 3D for less radiation effective dose than a digital pan in Ceph, which a digital pan at a young child is like 20, 25 microsieverts. And then add in a 5 to 10 more for a Ceph. Like you said, with film-based, anyone who had it done film-based was significantly more than that. And then people will say to me, well, with those low-dose scans, and I'm going to qualify this by the fact that I get in an adult or a surgical case or a cleft craniofacial case, you need to ramp it up to have a little more detail. But for 99+% of my patients, that low-dose quick scan, I could see so much more in even a less well-defined 3D than a very clear 2D, which of course it just makes common sense. And I mean, I talk to people in academia about this. I talk to people in private practice, and I think you hit the nail on the head. The two things you just said, change is really, really hard, especially when things seem to be working pretty well. And you have to add in more time and cost to the process. And those two things can be pretty strong deterrents at the end of the day.
Yeah, I mean, I don't know why you wouldn't want the information.
Right, especially if you can detect an airway issue that then lets them get the appropriate care from your medical colleagues, who most ENTs are not doing endoscopy and looking up the nose with a scope on a 6, 7, 8-year-old. They're just rhinoscope, turning the nose up, looking in quickly. I'm not saying all ENTs, but I deal with a lot of ENTs, and parents come back and say they literally just looked up their nose with the little rhinoscope. They didn't go in with a endoscope. So if we can send them those 3D images and show them the extent of the airway problem or the allergies and nasal passageway obstruction due to turbinate hypertrophy, when you detect these things on these young kids who aren't breathing well, even if you took it with a machine that's a little more radiation than 2D imaging, think of the quality of life change of this child that's now going to sleep better. So, I mean, it's above my pay grade to decide which is better, right? A little extra radiation or deeper well-rested sleep. That being said, I think we have to, as you said so well, look at this as a bigger picture of patient care and what we can do for our patients other than this myopic, nope, this is what I do, this is what we've always done, and this is the best we can do. We can always do better.
Always, yeah. I'm not sure why, but I think in order to grow, in order to develop, that behavior is going to have to change,
Yeah.
or those practices will go by the wayside because eventually that's just going to become more of a standard of care.
Yeah.
I can't imagine it not becoming a standard of care.
Yeah.
It does worry me a little bit with the DSO models. These practices kind of cash out. Mm-hmm. Now you're just kind of working, there's something to be said if you're going to be at that level, like being responsible for your patient, having your own practice. If everything becomes like a business model, mm-hmm. and then the new person who replaces George really never was an owner, it's like an 8 to 5. Okay. That does worry me a little bit about the quality of care mm-hmm. that big business is going to subliminally impose on, it's mm-hmm. like, well, you're just you're just an employee. And that's what's happened in medicine. It does give me a little concern. But for the most part, I'm really excited about just the whole future of our profession, because I think it's really one of the best professions anybody could have.
Oh, I agree.
It's just awesome.
I agree. And I am encouraged constantly, literally daily, by the young docs and the residents that I teach and coach. Yeah, they get it. Amazing. Oh, they get it. And they want to do more for their patients than, in my world, just be tooth straighteners, or in your world, just be scaling, root planing, and treating disease. And I think that's what it gets down to, is what you've been talking about, what I've been talking about. We're trying to increase and improve the quality of life of our patients, not just treat the symptoms. We want proactive care. We want, I often talk about Peter Attia and Outlive and the concept of medicine 3.0, as he calls it, where you're looking at things proactively, using clinical experience side by side with data to not just be this reactive treat disease or surgery for a problem, but go in and proactively, which again, your approach with guided tissue regeneration and SFOT and all of these concepts that, instead of just being like, well, we're just going to try to move your teeth the best you can, or move your teeth and have all these complications, you go, no, we're going to go in and rebuild the structure, the foundation for you, change the phenotype. Then we're going to do this. And not just are you going to have better functioning teeth, you're going to have better health and better quality of life. That's something that, to me, where perio and ortho can do so much more together, don't you think?
Oh, yeah, no question. It's not a push-pull like kind of thing anymore.
Right.
Like or super erect the tooth or upright the tooth. We have gone beyond that. Luckily, we had people like Vince Kokich who showed us that orthodontically we could develop bone with using teeth, and probably better than any bone graft we could ever do is use ortho. Mm-hmm. And then that is just expanded now to airway and the phenotype changes and so forth. Yeah, it's really remarkable. But it is hard, Mike. I will make no bones about it. The journey is hard. You have to surround yourself with really a good team that you can rely on and sees things the same way. I think that's very important. It's the team approach is what's key for the future. Mm-hmm.
And that lifelong learning that you were talking about before, right? Just constantly questioning and asking questions. I tell the residents all the time, you don't have to do it the way I do it or say to do it, or you, obviously if we're on a particular patient and I'm telling the resident they need to take a certain step, but I'm talking conceptually, like when I teach, and you don't have to follow Mike DeLuke's way of treating patients. I want to expose you to something, and then I want you to question me on it. Ask me why I'm doing it. And that's what you need to do all the time throughout your entire career. What do you think the biggest challenges are facing our profession? We mentioned one, kind of the corporate side of things. What do you think are some of the other challenges or impediments to people doing this that you have seen, in whether it be the perio side, the ortho side, the surgical side, the general practitioner side, when you talk to people who are opposed to this sort of thing or what you're doing or think it's unnecessary? What are some of the arguments they make for that?
Well, I think those are becoming less and less because it is becoming there's more in the literature. Mm-hmm. It is becoming more well known. Yep. But I think one, cost. Mm-hmm. I think cost, not just cost of care, but also cost of like technology is expensive. Yep. And then I think really being able to kind of language things properly, right? I mean, most of us want to be liked, but it's easier to kick the can down the road or say things that a patient wants to hear rather than to tell them what they really need and what our profession can do.
Interesting. So not with the language with the patient. Interesting. Okay. Yeah.
The language it in a way where, you kind of build this, like Paul Haney would say, you build this bridge of what the patient thinks of dentistry and what we can accomplish, and then have them start to ask the questions as to how can they get better and improve those things, which he, like Brian, are like co-discovery. I mean, those guys are masters at that. And then also to get the skill set to be confident in what to do and how to do things, and to really just have patients see that. I think that's key. But I think certainly the cost of treatment is a barrier for sure. And then the technology, the cost of just ramping up more and more technology is not inexpensive either. Yeah. But there's no question that there's an incredible benefit, but some of this treatment is complicated and it's expensive. Yeah. I mean, there's just no way around it, right? Right. I mean, it is expensive. Does
insurance cover much of like SFOT or?
No. I mean, not it depends on the plan of the patient, but I would say not particularly. But I will also say when the patient has the value, it's the best money they've ever spent.
Right. And that's so key. Right. Yep.
Money well spent. Yep. Right. So, rather than going round and round and round on dental problems, I think really kind of stepping back, diagnosing, spending the time. And my consults are about an hour and a half at least. And I basically tell people it's just a data collection. I mean, I'm going to just collect all this data. We're going to talk a little bit about a 30,000 foot view of what I'm seeing. But what I would really like an opportunity to do is to have you come back in a week or two, and I'm going to think through in your entire case, talk to your orthodontist, and then we're going to put a plan together for you based on your preferences and goals. And then I'm also going to give you a couple of options as well. And I will tell you, that has been transformative for me because most people feel like they need to have an answer in this 1 hour consult. You have to spend time to think through these cases. What you may see on a scan may sometimes be so different than what you think you're going to see in the patient. And you're like, whoa, this looks totally more vulnerable, much more complicated. I need to think through this a little bit more. I think people immediately start to recognize that you're a little different, and they really appreciate being taken care of as an individual. Yes. And the fact that you're going to spend the time to go through their care on a very personalized level and be very honest with them. And then once you bring that barrier down, then you can have the discussion about, hey, is this something you can afford? I'm not going to judge. I'm going to tell you this is what I think is best because this is what we can do. We can phase it. We can do this. We can do that. Is this something you think, you want to pursue? Yep. So that I think has been super, super helpful. And that's the way I try to approach most of the care today. I do tend to see a little more complicated cases, but I just need them to know I'm going to think through their case, and I need the time away so that I can just plan and think through the cases. I feel much more fulfilled doing that too, because I feel like I'm doing the right thing for the people that are entrusting the care of their patients to me, and I feel like I'm doing the right thing for the patient. And I go home and I feel like maybe I don't know everything, but I did the very best analysis and thoughtfulness for that patient that I could. And I think that just tends to breed success. Yes. I think that's just going to continue to kind of like, people are going to talk about it, and that's just going to breed success. So if you do that, you don't have to worry about like, where's my next patient going to come from? It's just going to happen.
I agree. They value it so much more. They get to know you for being different and thinking about things differently. People in my field talk a lot about, 2 phases and the cost of 2 phases, or don't use their whole insurance benefit in 1 phase. And that is, as when I had Claudia Pinter on, she referenced, that's letting the reimbursement drive the care. So I get it. We have to be sensitive to the patient's means. But as you just said, well, then you offer various types of treatment options and things we could do. That doesn't mean we don't tell them what's best for them and what could happen if we do ABC versus DEF, so to speak. So if we go to them and show a parent, in my case, where the child isn't breathing well, where they have obstruction of their nasal breathing, where they're growing with this narrow, high vaulted palate, narrow arches, significant crowding, vertical grower, all of these things we see, it's not easy for these parents. Now, all of a sudden, I'm telling them they got to see the ENT and or the allergist and maybe an oral myofunctional therapist. And they're like, I just came in because my kid's got a couple crooked front teeth at 6-7 years old. But again, if you just walk in the room and you say they need to do this, and so-and-so is going to tell you how to schedule this, you're going to lose people because you haven't created the value and had them understand it. So it does take that extra time to say, this is what I'm seeing. This is why this is problematic, and this is what we can do about it to chart a better course than the reactive approach where we just let this keep going and try to clean it up down the road. And I agree with exactly what you said. When you do that, it's surprising how few people object to that. And then when you produce the results, which you invariably do with this approach, not that every case is perfect, but the vast, vast, vast majority treat out beautifully when you have this type of approach, whether it be in your perio side or my ortho side, or both, the patients then tell other patients and other patients. And as you said, the patients just keep coming because they're like, I want that type of heightened level of attention and care, is what I found.
I want the healthcare. Right? They want to be better. And this is why these podcasts, what you're doing is so important, because this is changing the profession. We are emphatic on, like, our colleagues need to embrace this because they are the mouthpieces and the showcases of how dentistry is going to be perceived in the community. And it's beyond what we learned in dental school. Mm-hmm. And it's incumbent upon them to really change the behavior, change how a patient perceives us, and really help move our healthcare industry to the next level, right? With purpose, with not scarcity, but with abundance. And because that's really what it is, abundance out there. It's not, normalized patient, it's about abundance. And I think that's just a slow grind, but it eventually the greater community are going to recognize, they hopefully in 10 to 15 years, 20 years, hopefully, my daughter will be going to the orthodontist asking the question, how are you going to improve my child's airway, right? How are you how are you going to make the teeth straight? How are you going to improve the airway for this patient so that, so that these things will be a part of what contemporary orthodontics is. It's expected of orthodontics and what they're capable of.
Right. And how are you going to normalize the growth so we're not dealing with a mess when they're 13, 14 years old, right?
Yes, exactly.
Yeah.
Exactly. Yeah. So that's exciting.
Well, I'm going to let you have the last word with that. That was awesome. That was really fun having that conversation with you and getting to hear more deeply into your background and what got you to this point and really uplifting this profession. I appreciate the kind words on the podcast. I love doing it. And this is why I love doing it, to have conversations with people such as yourself. This is what it's all about.
Yeah. Well, it's a team, right? It's about team. It takes a village to change. And
it does.
I love the interdisciplinary approach. It's my passion. I love the relationship building, and love the opportunity to work with other specialists and restorative dentists. And it's just been a pleasure to be able to communicate my passion with you today.
Well, so I appreciate that. And
it's
my pleasure. And it's evident in everything you do, and seeing the work you've done in your lecture. You are very gifted in what you do and the cases you treat. You're very humble, but you are amazing in what you're doing, and the things you're doing for your patients is really, really amazing. So how do we get people?
I've stood on the shoulders of giants. That's all I can tell you. If I've done anything, it's because I've surrounded myself with the right people.
And that's another great lesson, right? Keep around people that keep pushing you, make you better. And it's evidenced by what you're doing and keeping you contribute. And thank you for giving back with the book. I know from writing and doing the things I'm doing, it takes time. So in addition to being a busy clinician, I really appreciate you and acknowledge you for continuing to give back to this profession, really, because you could just be doing all this, you've learned from all these other people, and you could just keep it, but you're going and passing it along and passing that baton and sharing it. And that is not easy to do. I have no idea how you wrote a textbook like that full time in private practice, plus lecturing and everything else you do and teaching it. I have no idea.
I have an incredible wife who's very understanding. And so that's, she's really the wind beneath my wings. She's really been the reason why I've been able to do what I do. I've had great partners as well, great staff who believe in our mission and just love what we do. So,
Well, kudos to you. So I'll put a link to the book, but anything else as far as people reaching out to you or contacting you or anything else you want to let them know about that I can put in the show notes?
For those people that are interested in learning more about corticotomy surgery, and I'm doing some live mentorship training, and then probably next year we're going to start on like a day course on how do you build SFOT into your course. So maybe those people that aren't doing surgery all the time but want to know, like, how do I beyond the boundary conditions? How do I have a patient with thin gingiva? I have patients that need orthodontics. Like, how do I plan these cases? We'll be giving a course on how to build SFOT and phenotype modification into your treatment planning. So two different courses given. The surgical mentorship is going to be November 7th through the 9th. So 2.5 days. So
can I put some link? Do you have any links for that yet? Or is it?
Yeah, I have a QR code. I can send it to
Beautiful.
you.
Yeah, I'd love to put.
It'll be a really special course. I don't think there's really anything else like it.
Awesome. I'd love to put that in there. So thank you.
And also show all my problems. I'm not going to hold back. I'm going to show like, hey, man, this is what I've had to deal with, and you're going to have to deal with. So I'm not just about showing how great things are. It's also showing about these are some problems that can happen. So be aware and know how to manage it.
That's awesome.
Yeah.
Well,
yeah.
Dr. George Mandelaris, absolutely a pleasure. Really, really enjoyed this, and thank you so much.
Thanks so much.
All right. Bye. All right. Thank you for tuning into this episode of the Doc Podcast. Be sure to visit theorthocoach.com to get access to ADA CERP recognized CE courses or to schedule a private one-on-one coaching session with me. Also, if you know of someone who would make a great guest for this show, or if you'd like to be a guest yourself, please email me at drmike@theorthocoach.com. And be sure to join the Doc community on Facebook for more great content. Thanks so much for listening, and always remember, you have been blessed with the ability to do amazing things.